People are still trickling in. We're going to give it a second and then we will get started. All right. So good evening, everyone, and welcome. I'm Jenny Tassler of the Associated Medical Schools of New York, and welcome back to the AMSNY Diversity in Medicine series. Tonight, we are focusing on surgical oncology as a part of a series of webinars that AMSNY is hosting in partnership with Memorial Sloan Kettering Cancer Center. Just a few housekeeping notes before we get started. Due to the size of the webinar, we've placed everyone on mute for now. However, we do want this to be an opening and engaging event. So if you can keep your camera on, especially if you're asking a question, we would really appreciate it. We will have time for Q&A from the participants to ask questions. So we encourage you to ask questions. Let us know if you have a question by putting it in the chat, or we'll have a time when you can raise your hands and ask your question. So I'm going to get started with a brief introduction of our speaker tonight, Dr. Tracy-Ann Moo. Dr. Moo is a surgical oncologist specializing in breast surgery at Memorial Sloan Kettering Cancer Center. She attended medical school at SUNY Stony Brook and did her general surgery residency at Weill Cornell Medicine, followed by fellowship training in breast surgical oncology at Memorial Sloan Kettering. She has particular expertise in nipple-sparing mastectomies. She is here tonight to share her background, her career path, as well as introduce you to some of the opportunities at Memorial Sloan Kettering Cancer Center. So welcome, Dr. Moo, and I'll give the floor to you.
Thank you, Jenny. It's my pleasure to be here tonight with you all. Thank you for inviting me. It's actually very nice to be the first speaker in this series, and nice to be able to talk to you guys about a little bit about what I do at Memorial Sloan Kettering. So I'll start with a little intro of the organization. Many of you who are from the tri-state area will probably be familiar with Sloan Kettering. I think it's pretty well known for cancer in this area, but also statewide. We're specialized hospital, so we treat essentially only cancer. And I'm just going to get my slides to advance here. Okay, so basically, Sloan Kettering started as a New York cancer hospital back in 1884, and we're the oldest cancer-focused hospital in the world. So that's quite a distinction. We started out on the Upper West Side, so the old building on the slide, on the previous slide, was located on the Upper West Side, so that's the west side of Central Park. But now our location is on the Upper East Side on 67th Street and between York Avenue and First Avenue. And here you can see in this picture our main hospital building, which is quite old now. I think we've been in this location for almost 100 years. And we're in the process of building another tower, but we do have already quite a footprint on the Upper East Side of Manhattan. You'll see that these are our locations. So in addition to our main hospital that's on 67th Street, we have multiple other buildings that are used for various other outpatient services. So when you're coming to Sloan Kettering, you could be either on the Upper East Side, Midtown, or Long Island, or New Jersey, or Westchester. So we've spread out quite a bit. So in addition to having our main hospital in Manhattan, we do have these regional sites where we do a lot of our outpatient activities, meaning we'll see patients in clinic, patients can have radiation or chemotherapy. It's just a better way to take care of patients closer to where they live. So patients who live all the way out on Long Island don't have to, drive all the way into the city to get all their care. So it's been part of our model for the past couple decades, and I think has been working quite well. So you'll see Memorial Sloan Kettering signs all over, not just the tri-state area, but Long Island, New Jersey, and in Westchester. So we are quite a large institution. We have over 22,000 people working here. In the hospital, our inpatient beds are over 500, so quite a large number of beds. And if you think about this being only dedicated to cancer patients, then sort of you'll realize just how big we are. There are some hospitals that treat everything that have 500 beds. So for being a specialized cancer hospital, that's quite a large number of beds. In the year 2020, we had over 22,000 patient admissions. So we take care of a lot of cancer patients. And this is also seen in our outpatient centers. So that chart I showed you with all of our centers sort of all over the tri-state area in Long Island, we see patients over almost 300,000 patients in Manhattan, but in our regionals, we see close to 200,000 patients. And we also now do a lot of telemedicine, which is, this increased during the pandemic. And now we're at over 300,000 of those visits per year. Sorry about that. Somebody's trying to reach me here. So this is our logo, and you can see it on my jacket here and sort of here as well. And it basically represents what our aims are, or our goals as a hospital are. And it's really to deliver excellent clinical care. So we want to take the best care of cancer patients, to do research to basically move the field forward. So we not only take care of patients, but we try to move the dial in terms of how patients are cared for, and basically improve our knowledge of the disease and how we treat it. And also to educate the next generation of doctors. And so education is a really important part of our mission here at MSK. This shows you basically the breadth of our involvement in education, which is really under the Office of Graduate Medical Education. They sort of oversee all of these activities, but our trainee population is over 2,000 trainees, and this includes medical students who rotate through summer medical students, medical residents, clinical fellows, and then rotating clinical trainees. And our GME office has over 80 full-time specialized programs, and this covers all areas of medicine, essentially. So from medicine, which is, general medicine, surgery, to pathology, radiology, pediatrics, radiation oncology. You can see here we cover quite a large number of specialties. Of course, within our hospitals, these specialties will be focused on the cancer patient and management of the cancer patient. But in treating the cancer patient, we also need all of these specialties involved. And this shows specifically our surgical oncology programs that are run through the GME office. And you can see here, they're quite a large number because cancer care is very specialized now. So if you can think of a part of the body, there is a specialty for that. So you can see breast surgical oncology at the top of the list. That's my specialty. I'm a breast surgical oncologist. We also have colorectal surgical oncologist, dental, maxillofacial. So this is, to do with the face, the nose, the jaws, reconstructing all of that and managing cancers in those areas. Head and neck, musculoskeletal, the eyes, children, so pediatric oncology, complex surgical oncology, basically the entire abdomen is covered there. Plastics and reconstructive surgery, this becomes a very important part of cancer care because a lot of times when we're treating cancer, we're removing a part of the body, and the plastic surgeons are really important for maintaining quality of life and helping us to reconstruct those organs once we've taken care of the cancer. And then we've sort of expanded now to have other departments that are intended not just for care here in the tri-state area and in the US, but also global cancer disparities, and basically having a global reach and trying to extend the good cancer care that we provide here to other places in the world where they may not be so fortunate. So you can see we have a lot of programs dedicated to surgical oncology. So touching a little bit on how I got here, I am originally from Jamaica. You can see a picture of me here with my grandmother. I must have been maybe 3 or 4 years old in that picture, but she was my inspiration for becoming a doctor. Basically, in my family, I'm the first doctor in my family. So I grew up in a family where the doctor was probably the most important person in our lives, or the person that my grandmother looked up to the most. It was, going to her doctor visits and talking about doctors. But she was a cancer survivor. She'd had uterine cancer before I was born, had radiation and surgery, and later had a recurrence, which was also treated. But I grew up sort of with her talking about doctors and said, well, I want to be a doctor one day so I can take care of you. So that's where this all began. Eventually, I was able to become a doctor. I wasn't able to take care of her, but I've been able to take care of all their family members, which has been nice. And I am now, as you can see on the right-hand panel of the slide, a breast surgical oncologist, which is for me, it's been quite a journey. So what does my day look like, or what does my week look like? So in most specialties, there's a combination, in most surgical specialties, there is a combination of operating, so being in the operating room, and seeing patients in the office. So I spend 2 days seeing patients in the office, and this is where I'll see patients with new diagnoses of cancer, where I'll sit down and I'll talk to them about management of their disease, what their prognosis is. And these are usually pretty long conversations, going over treatment options and sort of addressing all of their concerns. And then we usually schedule surgery. And I also see during my clinic days follow-up. So people who have had surgery a week or 2 ago, I'll then see them in the office to review their pathology reports and talk to them about what the next steps in their care will be. And then I spend 2 days in the operating room where I actually do surgery. And those are the bottom 2 pictures you'll see there. These are very sort of intense days, long days. Where I start normally by 6:30, 7 o'clock in the morning. Usually we have a meeting or 2 in the morning on certain days. So we'll have those meetings starting at around 7. And then I'll be in the operating room by 7:30, 8 o'clock. We usually end by 5 to 7, depending on how many surgeries we have that day. So they can be long days, but they're very fulfilling days. And most people who go into surgery actually like the sort of action behind it all. So you're doing something all day, and you're actually doing something where you see the end result immediately. So I have a patient with cancer, I take them to the operating room, I take out the cancer. When the operation is done, usually the cancer is gone. So you see your results immediately, and that's one very fulfilling part of our practice. And then we're also usually on call to take care of issues that come up with our patients. As I said before, we're lucky in that we have lots of residents and fellows. So residents and fellows will usually take care of the day-to-day management of patients on the floor when they're in the hospital, and they'll communicate with us when there are any problems. And also the morning after surgery, I usually see my patients to make sure that the ones who've stayed, who are in the hospital overnight, I'll see them with the resident in the morning, and we'll make sure that everything is as it should be, and talk about when they'll be going home. Now we're actually able to do some of this using televisits. So in our newest facility, we have actually cameras in the patient's room, so I can call into their room and talk to them from Long Island. So if I'm in Long Island seeing patients, I can still call in and talk to them in Manhattan to see how they're doing after surgery. So that's one really nice thing that we can do with our technological advancements. So this is where I do most of my surgery. It's our Josie Robertson Surgery Center. And if you guys ever rotate here, I've had, pipeline students who've worked with me over the summer, and they usually spend a couple of days shadowing me at Josie Robertson, where we do most of our mastectomies and our lumpectomies. And it's a very nice facility. It's about 6 years old. There's a very comfortable area for patients to and their family members to stay while they're waiting for their relatives who are having surgery. And the patient areas are also very nice. So patients usually are happy there, even though they're not happy to be having surgery most of the time, but they're happy with their surroundings once they're there. And the staff, everybody is really incredibly nice there to everyone. So our students enjoy being there as well. So just to touch a little bit on actually what I do in breast cancer in the US. So these are stats from the SEER database. And the SEER database is this national organization which collects data on multiple different types of cancers in the body, and basically organizes the data so we can generate these statistics that tells us basically how we're doing with treating these cancers. So if you look at breast cancer stats, you can see that, in 2020, we had over 200,000 cases, 276,000 cases, and that was about 15% of all new breast cancer cases. In terms of the overall survival of all comers, so all patients who present with breast cancer, the likelihood of surviving your cancer, so being alive at 5 years after your diagnosis, is about 90%, which is pretty good. If you go back maybe 2 decades ago, this number was much lower. So we've actually done quite well in terms of survival for breast cancer. And this again is just a graphic that shows you of all patients presenting with breast cancer, the 5-year survival is about 90%. So survival of breast cancer depends on the stage of presentation. So you can see in the upper panel on this graph here that most of our patients will present with what we call localized disease. So that's disease that's confined to the breast. And that's about 63% of our patients. Another 30% will have spread to the lymph nodes. So that's the lymph nodes underneath the armpit, that's regional spread of the disease. And about 6% will present with cancer that's metastasized to another part of the body. So it's gone to somewhere else, like the bones or the lung or the liver. And luckily, that's the minority of patients, because the prognosis, meaning the 5-year survival of patients, is determined based on their stage of presentation. So if you look at the lower graph, you'll see that patients who present with localized disease, the green bar, their 5-year survival is about 99%. So it's better to detect the disease earlier because your survival is better. We can treat the disease better when we find it earlier. When there's been regional spread, the survival drops a little bit, quite a bit, I'd say, to 85%. And when you present with distant disease, so patients who present with disease that's already gone to some other part of the body, the survival really drops to about 28%. So this is why you'll see all those campaigns for screening, finding breast cancer early, is because when we find it earlier, the prognosis is much better. And here, this tells us who gets breast cancer. So if you look at breast cancer, it's really more a disease of women. Men do get breast cancer, but it's rare. And among all races, the prevalence is highest among white women, followed by Black women, and then Asian Pacific Islanders and Hispanic women. In terms of the age at which women will present with breast cancer, it's really a disease that's seen mostly in women in their mid-50s to mid-60s, 70s. So you can see by this chart, women in their less than 20 almost never get breast cancer. Women 20 to 30, there's a much lower percentage. So about 2% of those, all the breast cancer that we see will be women in that age group. And then the prevalence starts to increase as you get into your 30s, 40s, but again, quite low. Then as you get closer to your 50s, you'll see we go up to about 20%. And then up to 25% in the 5th and 6th decades, so in your 50s and 60s. And then you see the prevalence starting to drop again as women get older. So it's really a disease of women in their 50s and 60s, with the average presenting, the median age at diagnosis being 62 years old. In terms of trends over time, I mentioned this briefly. So the incidence is increased by small portion of a percent by 0.3% per year over the past 10 years, but death rates have fallen by 1.8% per year between 2006 and 2015. And this has really been due to us being able to find cancers at an earlier stage, so they're more treatable, and also advances in the way that we treat breast cancer in terms of the therapies that we give, systemic therapy, the combination of surgery, chemotherapy, radiation. So our treatment for breast cancer has changed tremendously, and that has also led to a decrease in the death rates, which is great. So I've mentioned briefly screening, and that screening is important because it allows us to find disease when it's at an earlier stage and more treatable. So how and when do we recommend screening? So screening is the age at which you start screening depends on your family history to some extent. And we used family history and a few other factors to determine whether or not a woman is at average risk or higher risk for breast cancer. And women who are at higher risk, we sometimes recommend genetic testing, which is looking for a gene. It's called the BRCA gene mutation, which predisposes to developing breast cancers. And so we tend to look at women's history and members of the family who've had breast cancer to see if we need to screen for these genes, because having these genes will put the woman into a much higher risk category for breast cancer, and we would test for the gene if we found that they had multiple family members with either breast or ovarian cancer, the criteria listed here, and then we would screen them differently. But for the average woman without a strong family history of breast cancer and without symptoms in her breast, meaning she's not feeling any lumps in her breast, she doesn't have any nipple discharge, we generally recommend starting to screen at age 40. And screening is usually with imaging and a clinical breast exam. A clinical breast exam meaning an exam by her gynecologist or the primary medical doctor. And then imaging is usually a combination of a mammogram, ultrasound, and sometimes when the woman is more high risk, we'll add an MRI. So what is a mammogram? A mammogram is basically an X-ray of the breast, and it's an X-ray of the breast that allows us to see essentially what's going on in the breast. And we can really see more masses in the breast and sometimes what we call calcifications, which are just little white dots that show up on the mammogram. In this case, you can see this woman is getting a mammogram. It's uncomfortable for some people, but it's quite short. But it gives us a picture that you can see over on the right-hand panel. And this is a picture of a breast cancer. You can see this little spiculated mass here, and that's basically the way that a breast cancer shows up on a mammogram. We do another type of mammogram called a 3D mammogram or tomosynthesis. And the benefit to a 3D mammogram is it allows us to see smaller cancers. A 2D mammogram basically gives you two images of the breast, one looking from the top down and one looking from the side, whereas a 3D mammogram basically gives us the various cuts through the breast. It's almost like a CAT scan. So it takes multiple slices through the breast so we can actually see in better detail what's going on in the breast. So this is a picture of a 3D mammogram. So you can see over on the left-hand panel a 2D mammogram. So this is an image that you would get if you basically just took one shot of the breast, sort of from side to side. As opposed to the 3D mammogram where you'll see these series of pictures and you'll see them labeled here 36, 40, 43, 46. So we're taking basically multiple slices through the breast. And as you go through each slice of the breast, you'll see this little mass coming into view here on slide number 43. And you could not really see this mass on the 2D mammogram, right? It's hidden in the tissue that you can see here. But when you basically cut the breast into thinner slices, by X-ray, you can actually start to see the mass. So the 3D mammogram gives us a much better picture of the breast. You'll sometimes hear people talk about density of the breast with respect to mammograms. So they may say, oh, my doctor told me I have dense breasts. And what does that mean? The density of the breast basically just gives us an idea of how much white areas there are in the breast. So as I said before, the mammogram is a picture of an x-ray of the breast, and fibrous glandular tissue shows up as white, fatty tissue shows up as dark. So if a woman has more fibrous glandular tissue, and this is purely genetic, she will have more white on her mammogram. So you'll see level 1 density, there's more dark areas on the mammogram, and cancers show up as white. So this is important because if there are more dark areas, it's easier to see a white cancer. If there are more white areas, the cancer can sort of hide in that white area. So it makes it harder for us to see. So level 2, you'll see there are more white areas. Level 3, much more white areas. And level 4, it's pretty much only white areas. So you could imagine in a breast that's level 4, it's kind of hard to see a cancer. And this is an example of that. So you can see in this breast over on the left-hand side that's not very dense, you can see that cancer pretty well there, right? So this is a breast that's quite fatty. Whereas in a woman who has a breast like this one on the right side, there are lots of white areas. It's very hard to see the cancer in that area. So women with dense breast, for women who have dense breast, the mammogram is not as sensitive, meaning that we have a higher chance of missing a cancer in a breast that's dense. And so that's why we usually recommend women who have dense breasts also get an ultrasound at the time of screening. An ultrasound is basically using sound waves. So it's a machine, you've probably seen this in OBGYN, where you take an ultrasound of the baby, you can see the baby. So it's the same thing we're doing in the breast. So it's sending sound waves through the breast, and those sound waves reflect and give us a picture. And basically when there's a mass, it shows up like this picture here on the right side. So you can see there's a dark area within all of that white stuff, and this shows us that there's a mass at that area of the breast. And this is another way of looking at the breast, and we usually add this when the breasts are dense. Another way of looking at the breast is by using a MRI. This is a more involved test. It's about an hour. We need to put an IV in, we give contrast into the veins. And what the contrast does is it enables us, it lights up abnormalities in the breast. So you can see this is a 3D reconstructed picture of the MRI, and you can see in this breast, you can see the vasculature. So these squiggly things all over the breast, those are the vessels, the blood vessels. And then you can see in this area a mass. So the MRI gives us a very good picture of breast cancers. And so but it's a much more involved test. So it's very expensive. So we don't use it for everybody. We only use it for patients who are at much higher risk of getting breast cancers. Sometimes women actually feel the cancer, maybe that they're not doing their mammograms, or it could be that it's a cancer that's a little bit more fast growing. And in this patient, she actually presented with a palpable mass, and you can see that the mass was causing a deformity in her breast. So you can see in her right breast here, you can see there's an area of retraction here where the skin is pulled in. And that's because of the mass was basically causing that skin to retract. And this was her mammogram and ultrasound. So you can see here, this is a mass that was sort of behind the nipple, and on mammogram in the top panel, and on the ultrasound, this is what it looked like. So what happens after we've diagnosed a breast cancer? So after we've diagnosed a breast cancer, and with the women actually come in to see me in clinic, I sit down and I talk to them. I look at the mammogram, I look at the ultrasound. First, they've usually gotten a biopsy. So, when we see an abnormality, we biopsy it, which is taking a little piece of the tumor with a special needle and sending it off to the pathologist. They'll look at it under the microscope and they'll say, this is breast cancer. And so then I will see the patients in clinic, and I will go over with them what their options are in terms of surgery. And for most women, they'll have the option of having what we call breast conservation. And you'll see that in the left-hand panel. And breast conservation means basically I don't remove the whole breast, I only remove the area of the tumor. And we combine that with radiation. And that gives us pretty much the same result as a mastectomy, where we would be removing the entire breast and then reconstructing it. There are some instances, though, where the woman is not going to be a candidate for breast conservation and will have to recommend a mastectomy. And those include times when there is a special type of breast cancer called an inflammatory breast cancer, or when there's disease in multiple areas of the breast. So it's not possible to perform a lumpectomy, meaning just remove the area of the tumor. So this is a picture of a patient who had breast conservation. So you can see here, there's a scar here on the breast where I've basically gone in there and removed the tumor from there. And then underneath her armpit here, you can see a little scar, and that's a scar from the sentinel node biopsy. So the sentinel node biopsy is basically just checking the lymph nodes to make sure that there hasn't been any spread of the cancer to the lymph nodes, as we talked about in the charts earlier. Most patients will have tumors that we can't feel, meaning we can only see them on mammogram, but I can't feel them on exam. So in order for me to remove that tumor, I need to be able to find it. So what we do is we put a little radioactive seed into the tumor. You can see it here in the mammogram. It's right here. So you put a little radioactive seed there. It emits a signal to me, so I can use a special machine during surgery, and I know exactly where that tumor is. And here you can see the little picture of the tumor once it's been removed. This is again an X-ray, and this little thin sort of rod-like device here is the radioactive seed. I mentioned before a sentinel node biopsy checking the lymph nodes. So the way we check the lymph nodes is we basically inject a dye in the area of the tumor under the nipple, and that dye travels along the lymphatic channels to the first group of lymph nodes that are draining the breast. Those are called the sentinel nodes. And at the time of surgery, I make a little incision under the armpit. Remember the incision that you saw on that patient on the arm? So that was from her sentinel node biopsy, where I made a little incision, removed the lymph nodes that were lighting up. And that I send those lymph nodes to the pathologist. They'll look at them under the microscope and tell me if they're positive or negative. And that tells me if there's been any spread to the lymph nodes or not. What's significant about this procedure is that it's really a leap forward in terms of the way we figure out what's going on in the lymph nodes, because maybe 15, 20 years ago, in order to figure this out, what we used to do is remove all of the lymph nodes from underneath the armpit. That was called an axillary dissection. So every woman who would come in for breast cancer or to have breast cancer surgery would have all of the lymph nodes removed from, well, not all, but levels 1 and 2. So most of them removed from under the armpit. And this was not a good, this was not good, because then we had a lot of women presenting with lymphedema. You can see this woman here, one arm is bigger than the other, it's swollen, and that's permanent. It's a permanent swelling of the arm. A lot of women, basically 20 to 25% of women having an axillary dissection would get this complication. And so by only removing a couple lymph nodes, we're really saving a lot of women from having lymphedema, this complication. So just to talk a little quickly about the other option, which would be mastectomy. Again, most women are candidates, especially women who have breast cancers found on screening imaging. Most women can do breast conservation, but some women just are not candidates for breast conservation, or they want to have a mastectomy. And in this case, we'll go through a little bit the different types of mastectomy. This is a radical mastectomy. This is basically the way mastectomies were performed years ago, I would say at least 30 years ago. We don't do mastectomies like this anymore, unless it's a really actually, we don't do mastectomies like this anymore, very rarely. But they would basically remove the breast, the skin, and all the muscle. So you're actually just seeing her ribs here. And then they would basically take a skin graft from somewhere else in the body and sort of just graft the skin over that area to close the wound. So it was a very deforming procedure. Now we have 3 types of mastectomies that we do. So the first one is a simple mastectomy. So this is on a woman who just decides she doesn't want to have any reconstruction. She just wants to remove the cancer. And basically we do what's called a flat closure. So we remove the breast and you basically close the wound with a straight incision, basically. So the chest wall is flat. And for women who choose to have a simple mastectomy like this, they basically have a special bra that they get fitted with afterwards that has a prosthesis in it. So they look very similar in their clothes, but their chest wall is completely flat. The other type of mastectomy that we do is a skin-sparing mastectomy, and you can see this in the middle panel. And this is a woman who basically she's had reconstruction. So we remove the nipple areolar complex. So the nipple and the areola is gone, and the incision's closed in a flat line. And there is an implant. We leave the entire skin envelope so that the plastic surgeon can then put an implant in that envelope. And so when she has on her clothes, it looks pretty similar to a natural breast. The other type of mastectomy that we do now, so this is sort of the progression. So we stopped doing the radical mastectomy, started doing more simple mastectomies, then went to skin-sparing mastectomies, and now we do a lot of nipple-sparing mastectomies. And you can see this in the last panel here. This is a patient who we basically make an incision underneath the breast, remove the breast tissue through that incision, leave the nipple areolar complex and all the skin, and the plastic surgeon puts the implant or breast tissue, the patient's own breast tissue, through that incision. So the incision's hidden and it looks pretty much like we haven't done anything, but there's no breast there. It's really just an implant, and the nipple areolar is in place. Most women, you know, who are diagnosed with breast cancer, they will survive and they will save their breast. But this is sort of a little snippet of how we manage breast cancer. I'll talk a little bit now about some of the opportunities that we have for medical students at MSK, and this is really great. I've had the pleasure to have participated in some of these programs. I wish I knew about them when I was a medical student, but there's a few options for spending time here, and we love having students here. It's really a pleasure to interact with students and to teach them. The first is a medical student summer research fellowship. And this is an opportunity to basically spend the summer here. Mostly medical students in the first and second year will be in this program. I think that's the only time in most programs that you have time to spend the whole summer doing something like this. You'll spend 8 weeks. You'll be mentored by one of our faculty members, and usually have a project that you present at the end of the program. There's also a medical student elective program. This is an opportunity to spend a shorter interval of time, and it's granted in 2, 4, and 8 week intervals. And then the medical student research enrollment, this allows students to spend a much longer interval here doing research. You're not necessarily here the entire time. You may be still in your program, but you basically have a relationship with us for about 6 months where you're doing projects and interacting with your mentor. And then there's a medical student observer program where you may just not want to spend, you know, the whole summer, but just a few days observing or seeing a specialty that you're interested in, and those observerships can be are limited to about 10 days per academic year. And I think you'll be hearing more and more about these programs in the other sessions in this series. So this is a couple of the projects that I've done with my medical students who've spent time with me over the summer. You can see in the first one, this is one of my projects where we looked at, we were trying to decrease opioid prescriptions. You know, there's an opioid epidemic. Before there was the pandemic, there was the opioid epidemic. And basically we were trying to manage opioid prescription in our breast cancer patients. And you'll see Rubaya and Ryan, they were both pipeline students who spent time with me at Josie Robertson working on this project. And last year, I worked with another student, Sue, who basically did another pain project with me that we just submitted this abstract to the Society for Surgical Oncology. So usually students will have a good time, but they'll also get some projects from this that, you know, can be on your resume. It really looks good when you're applying to your residency to have done some research. I really enjoy working with medical students in these programs. So hopefully in the future we may be seeing some of you guys applying to these. And this is a picture of my mom and I. She's been probably one of my biggest supporters and mentors. She was the first woman, the first person in our family to go to college. And then I was the first doctor in our family. So we have a couple firsts between the two of us that we're very proud of. So follow your dreams.
Thank you so much, Dr. Moo. We really appreciate you sharing all that information and your story. I think we're going to move to some Q&A. So again, if you would like to ask a question, please raise your hand and we'll make sure that you can unmute. And Otherwise, you can also put your questions in the chat and we can moderate that way. And don't be shy. Dayani?
Yes, Diani speaking. Thank you for calling on me. I just wanted to ask you a little bit more about, I guess, as I'm learning more along my journey about breast cancer, I've seen, you know, like just as an example, like family members or friends, family members, where sometimes they go the route of just taking like certain medications. At what point do you, like as a physician, I guess, because you were talking about like mastectomies, does a physician, I guess, as yourself determine whether someone with breast cancer can just go the route of taking just like the medications versus going through all the other methods that you were explaining? I guess I just want to know the differences.
So it sounds like if you've had a family member who just took medications for their cancer and didn't have surgery, it's usually that's pretty rare for treatable breast cancers or localized breast cancers. When patients present with localized breast cancer, the standard of care, meaning what we usually do, is to operate and then give additional medication, you know, as a part of that treatment. We give medication when tumors, when patients can't tolerate surgery, so they may be very old and frail, have a lot of medical problems. And if that's the case and we don't think surgery is safe for them, then we would recommend just taking the medications to try to manage, to keep the cancer at bay, you know, for as long as possible. The other cases in which we would just use medications is if the cancer, remember I showed you that graph at the beginning that some cancers present and they've already spread to other parts of the body, meaning the lungs or the bones. If that's already happened, then we usually don't do surgery for those cancers. Sorry. Hi, I'll be just a little bit longer. Yeah, go ahead. Yeah, no problem. Go ahead. Sorry, I'm just having my trash together. So in those cases, then we would only give medication because it doesn't make sense to operate on the cancer. There's no way to cure it by doing surgery. So the medication tends to treat the rest of the body as well as the breast.
So does that mean that the cancer technically, once it's in a distal area or another part of the body, that it falls in that category where the survival rate technically is a little bit lower case by case, correct?
Yeah.
Okay, that makes sense now. Oh, thank you. That's insightful.
Great. Thank you. Dahunsi.
Downsy, yes, thank you. All right, so for procedures where a patient has had a lumpectomy followed by radiation, has there been off-target effects due to radiation therapy?
So the more common side effects that you see from radiation are local side effects. So with radiation, you can think of it as basically giving X-ray beams to a localized part of the body. So the chest wall, for us, it's the breast area. And the more common side effects are local. So you can think of what happens to your skin when you're sitting out in the sun for a long time. So you can get some swelling, your skin can peel, some redness in the area. Those are the more common side effects. There are some other more rare and infrequent side effects, like a certain type of cancer that you can get from having had radiation, but those are very, very rare. There are also sometimes heart and lung side effects after breast cancer, and those also are quite rare with the way we give radiation for breast cancer now, because we're able to really target it very precisely. So I would say it's pretty rare to have very serious side effects from radiation.
Thank you.
Great. Giovanni.
Hi, thank you. I was wondering, when you were speaking about the dense breast and how they look light in the mammogram, or light gray, how they look white, I was wondering, for these people that might be difficult to find abnormalities that might need a 3D view, are those covered by insurance?
Yeah, it is.
Oh, okay.
So a lot of my patients with dense breasts will order a 3D mammogram for them for screening, as well as an ultrasound, and it's covered by insurance.
Thank you.
Manuel.
Thank you, Dr. Moo, for hosting and for presenting. So my question is relates to what Giovanni was asking. If tomosynthesis is a better screening technique for people or for patient that has denser breast, why isn't it the standard of care? Or is there any project that will make it standard of care, especially for people that has denser breast as opposed to a regular mammogram?
Wow, you guys are way ahead here. But yes, it is becoming standard of care. I think what was the limiting factor is up until a few years ago, many facilities didn't have the capability to do them. But more and more screening facilities have these machines that do 3D mammograms. So it's really becoming the standard of care, particularly for women with dense breasts. So any given facility might not have the ability to do a tomosynthesis for everybody, but they'll do them for women who maybe had breast cancer in the past or are higher risk or have, dense breasts. There's some women who don't necessarily need tomosynthesis. Like, as you can see, those really fatty breasts that I showed you that are not dense at all, you can see them really well with just a 2D mammogram. So you may not need tomosynthesis for those breasts, but it's becoming standard of care.
Thank you.
Do you find that patients have access issues depending on socioeconomic status or racial ethnic status or?
Yeah, definitely. I mean, we definitely see disparities in terms of access to screening that mirror sort of the wider disparities in our society. I think one good statistic, though, one thing I didn't mention is that African-American women have, even though our incidence rate for breast cancer is much lower than for white women, our death rate is much higher, right? And that's multifactorial. It was a much longer conversation. It has to do with access, has to do with the type of breast cancers that we get, treatment delays, potentially all of those things. But one good statistic is that in recent years, we've seen that screening amount among African-American women is just as high as among white women, which is good, meaning that we're actually making progress in terms of getting screening out to those communities and trying to reduce that disparity.
Great. Naomi.
Hi, good evening, everyone. My name is Naomi, and I'm a second-year medical student at the Kettering School of Medicine. And I just wanted to ask you, so you talked about how your family was a big inspiration for you and just other factors that led to you being on this career path, but I was wondering what other experiences maybe contributed to your success in this career, and if there's anything you would have done differently.
I think I had a lot of good mentors along the way and people who encouraged me to continue sort of along this path. And I think that's always something that we need, especially if you come from a background where you don't have doctors in the family, you don't necessarily know what the path looks like. I mean, I went into medicine saying that I wanted to take care of my grandmother. I had no idea what it meant to be a doctor, When I chose surgery, I mean, I didn't think I would be a surgeon just because I didn't know what that was. I didn't really understand that was what it was until I was a medical student. And when I was a medical student, I started my third year rotations, back then, was it more than 15 years ago? 20 years ago, when I started medical school, we started our clinical rotations third year. And I remember leaving the house and, my parents were, I was driving back to medical school and I said to my mom, it's okay. She's like, why don't you leave a little early? I was like, no, I'll stay a little bit later. It's okay. It's just surgery and I'm not going to be a surgeon anyway. And I ended up doing that rotation and really loving it. And for the rest of my third year, there was nothing that measured up to surgery. That's just where I loved, what I loved. So, I think keeping an open mind is important because especially when you come from a background where you don't have doctors and you're not exposed to a lot of medicine, then you don't really know what you're going to like. So I would just keep an open mind as you go through your training. And people who encourage you, stick with those people, okay? There will be people who don't encourage you, right? I mean, I had a professor in college who told me that I should be working in McDonald's, believe it or not. And I went home and cried to my mother, but you know what that did? That made me want to do it more. So there are going to be people who discourage you. There are going to be people who encourage you. You should stick with the people who encourage you and try to forget about the people who are discouraging you, because you can all do whatever it is that you set out to do, and then keep an open mind.
Thank you.
Janice.
Hi, my question is related to kind of research in breast surgery. I was wondering, Dr. Moo, what are your thoughts on like really like areas of breast cancer research that are moving forward right now and very like gaining a lot of traction, and ideas on how medical students can be involved?
Yeah, so breast cancer, unlike a lot of other areas of cancer, we've made really tremendous leaps forward in the past couple decades. And a lot of it has to do with tailoring our management of cancers to the biology of the cancer, the disease. So it's really, we figured out how to group cancers into what we call different subtypes and to treat them based on those subtypes. And so there's a lot of research in that area with really tailoring. And this has to be with the drugs that we prescribe to patients after they've had their surgery. So we tend to give them different drugs based on the type of cancer that we have. And there's a lot of progress now for the triple negative breast cancers. Those are cancers that tend to be more aggressive, more fast growing. And we didn't really have such good systemic treatments for them, and now we're seeing much better results with immunotherapy and other drugs that we're using. So there's a lot of sort of clinical trials that you'll see going on, looking at how different drugs behave. In the surgical world, we're doing a lot of sort of new procedures now to reduce lymphedema in the arm. So I showed you that picture of the woman with the swollen arm. So there are procedures now that actually the plastic surgeons will do to try to reduce for women who we have to remove those lymph nodes because there's disease there. We can do these other procedures to try to reduce the risk of them getting arm swelling. And then in surgery, we're also doing a lot of research looking at how we can cut down on some of the types of the surgery that we're doing. So more and more women will be able to have just a couple lymph nodes removed rather than removing all of them or a large chunk of them. So there's a lot of research in all of those areas. Breast cancer is a field where we're always trying to move forward. We're always doing research and trying to see how we can do things better. So there are always going to be questions to be answered there, Janice.
Great. Gordon.
Hi, good evening. Thank you so much for sharing so much of your experience and expertise with us. I wanted to know how does in breast cancer field, how do you make sure that it's an open environment or are working towards making an open environment for patients that are gender non-conforming, may not have a large experience with the healthcare system or have an experience with discrimination in the healthcare system, such as like people who are gay, lesbian, bisexual or trans, including trans men, who may not think of themselves or who may not know how to ask their GP to get like a mammogram, may not feel comfortable because of potential violence. And then also, what are some community level interventions that you see people in your field building, or would you like to see more of, or could happen? So sorry for the twofold question.
No, it's okay. Well, I mean, I think this is an important area and an area that's really having more attention now, as you say. It's an area where we tend to not have thought about before just because we weren't talking about these issues. And I think what we're starting with is education. We're really, if you go to our conferences now, I'm a part of planning one of our big surgical oncology conferences, and one of the talks that we just planned is around issues in the trans community with screening and breast cancer treatment and management, because we do see trans men, transgender men who've been on hormones for a long time, who are at risk of getting breast cancer and do need to be screened. And so those issues really do need to be addressed in that population. And there are slightly different issues related to sort of to that population. So I think we're starting with education, Gordon, and that's how we're trying to address it. I think it's a good place to start because that's where, after we've left medical school and training, that's where we normally go to our meetings to sort of stay on top of what's going on and to learn, to continue to learn. And it's really about teaching surgeons that, you know, already practice a certain way, that actually this is what we need to do now. So that's what we're trying to do.
Thank you.
Great. Thank you so much. Isaac.
Thank you so much, Dr. Moo, for your presentation. I really enjoyed it. And thank you for all the medical students for being here. I have two questions for you. So for the first question in which I had is that in continuation with the research which is being done with breast cancer research, what are some environmental factors in which is currently being researched as a potential risk factor for breast cancer development?
So environmental factors. So we tend to focus a lot on lifestyle, and a lot of our studies regarding risk of getting breast cancer again. So after we're treating it, breast cancer coming back focuses on lifestyle issues, such as diet, exercise. You know, we have studies that show us that women who achieve a normal BMI, so through, you know, we do these exercise programs where they're doing exercise 3 times a week and they achieve a normal BMI, have a lower risk of breast cancer coming back in the future. And the reduction in risk is comparable to what you might see for chemotherapy, which is a pretty amazing thought, right? Like, you can lower your risk of breast cancer coming back just by a healthy lifestyle, right? That's not by itself, of course. I'm not saying we don't need to do any of the other things, but you can get quite a big reduction by changing sort of your environment and your lifestyle. So we focus quite a lot on that. And a good thing about focusing on that is that, you know, when you improve your lifestyle, meaning exercise, diet, all of that things, you not only change your breast cancer risk, but you also change your outlook for other diseases, cardiovascular disease, other cancers. So that's sort of something that not just benefits you in terms of breast cancer, but all the other things. In terms of other environmental things, like women ask a lot about, you know, deodorants and things like that. Honestly, I'm not an expert in that, and I haven't followed the research on that. There's nothing I know that's come up recently environmentally that I would say is a big area, but I might not be the best person to talk about that.
Thank you so much for your answer to that question. The second question in which I had is, I know early on you mentioned the fellowship and pathway programs for medical schools. I was wondering if there are programs or shadowing opportunities for undergraduate students.
I would have to punt that one to Jake. Is Jake on?
I believe he is.
I am. So Isaac, hi everyone. My name is Jake Sneeve. I'm the director of the Graduate Medical Education Office at MSK. Isaac, what can you just say your question one more time for me?
Yes, certainly. I was wondering if there are fellowship or opportunities for undergraduate students that are looking for to get more involved within research or even shadowing.
You know, I think at our institution, you or other undergraduate students should just reach out to our office, and we can try to help facilitate. In medicine, it's very tough because anything that has to do with hands-on experience is very highly regulated in a medical environment. So with undergraduates, it is more challenging. With medical students, it's not as challenging. There are still challenges that we have, but for undergraduates, it's tough. Tracy, my colleague who actually manages our medical student programs, I'm going to actually also punt this to her to see if she has some additional info.
Hi. So there isn't exactly a program through the Graduate Medical Education Office, but there is a research program through another department that is held during the summer, and it's called SURP. That's the abbreviation for it. Definitely check our website. There's a few different undergrad summer research programs. They're just not run directly through GME because we do medical student and higher. But if you want to email me or Jake or anyone else, we can forward your contact information to the person that does run that program.
I'll also put in a plug here for AMSNY. We run a number of pipeline programs and we're very connected with opportunities available. So please shoot us an email as well. I'll ask Nyla if you could just drop the info address in the chat. We're always happy to help students who are looking for opportunities. All right, so I think this is going to be the last question, Giovanni, and then we're gonna wrap up for the evening.
Thank you for the opportunity. I was wondering, when you get that biopsy back, how do you go about having that conversation with the patient that they have cancer and it's spreading? It's not an easy conversation. Do they get referred to social workers? Can you speak a little bit about the support services for patients to help them process all of this?
That's really a good question, but it's a question that might take a long time to answer. You know, I go about it, I would say, with a lot of compassion and empathy, because it is, as you say, a very difficult diagnosis to get, and patients are in a very difficult time during their lives, and their family members are also in a difficult time. I'm lucky that I have a great team that works with me. I have a group of nurses that also help me to manage new patients, and they have a special questionnaire that they do with patients, and it tells us if they're having, there's this part of the questionnaire, there's a distress thermometer that we use for many of our cancer patients that basically asks them how they're feeling emotionally because of the diagnosis. And if they score above a 4 on that distress thermometer, we automatically will refer them to social work. And so normally when the nurse reviews with me that questionnaire, she'll say, you know, they need a social work referral. And then when I see that they need a social work referral, during my conversation with them where I'm talking about the cancer and what their treatment options are, I'll also talk with them about meeting with a psychiatrist to help with the diagnosis management. And some people may need just to talk to somebody. Some people may need some medication to help to manage their anxiety around the diagnosis, sometimes just temporary. So we have those resources here, luckily. And I think that's one special thing about getting your care at a cancer center, is that we sort of have all of these things integrated into our daily sort of workflow of taking care of patients. So it's not something that I say, oh, this patient needs a social worker, I have to go find a social worker. It's sort of all here and provided for the patient. So I think patients get really good care. Here, you know, I haven't worked at, this is the only cancer center I've worked at, but I think we really try to make the diagnosis and progressing with the treatment as easy as possible, because it is a really, really difficult time.
Thank you so much.
Okay, well, thank you so much, Dr. Moo, for taking the time to talk to the students, and thank you to the team at MSKCC for facilitating this. We really appreciate it. We are going to be hosting additional webinars in partnership with Memorial Sloan Kettering coming up, so we will definitely keep you on our list. And we also have regular webinars coming up every month and different topics, so look out for those flyers, and we hope to see you soon. Thank you, everyone.
Thank you.
Good night.